Good morning, everyone. I'll be presenting on safety and efficacy of suprachoroidal triamcin in retinal vein occlusion. So we know that macular edema in retinal vein occlusion is due to obstruction and retinal hypoxia. The hypoxia upregulates the level of VEGF, which leads to macular edema. So to address this primary problem of increased VEGFs, the treatment options are targeted towards reducing the level of VEGFs. So we have various anti-VEGFs and some recent ones also, and the response is clinically acceptable. In the past, various steroid injections into the vitreous cavity were used to be given, like IVTA, but cataract and glaucoma was the main concern, and which led to development of these steroid implants like Ozurdex, but we all know the cost is on the higher side. So recent studies, they address to this problem, and on the outcomes of depot steroid injection of triamcinolone into suprachoroidal space have shown favorable results in terms of improved efficacy, lesser side effects, and longer duration of action like the steroid implants. Some of the landmark studies like the Tanzanite study, which they have used suprachoroidal triamcinolone in combination with anti-VEGF agents with good results as compared to anti-VEGFs alone. So with this, this fact is established that this is definitely a recent addition to the therapeutic armamentarium of a retinologist, and triamcinolone drug is commercially available at a very reasonable rate. But the only hurdle is that the microneedle or the catheter for injection is not widely available out of the clinical trials. So all these microneedles and catheters, they are patented. So we lack the real world data on the use of suprachoroidal triamcinolone. So to tackle this issue, we modified a 26 gauge needle along with the sleeve of a 22 gauge intravenous cannula for safe and cost effective delivery of suprachoroidal triamcinolone. So this was a retrospective chart review of 20 patients who were treatment naive, and they were treated with suprachoroidal triamcinolone. The visual acuity was worse than 612, and they had macular edema based on OCT more than 300 microns. Known patients of glaucoma and other retinal pathology were excluded, and the follow-up of less than 6 months was also excluded. So to inject the drug, which I'll show you in detail in the video, we take this 26 gauge needle and the outer sheath of this 22 gauge cannula, so that only the beveled tip, which is roughly around less than a millimeter, remains exposed, and it reaches only till the suprachoroidal space. And like any other standard injection procedure, the drug can be injected effortlessly. So this is a short video.
We have used inexpensive intracath and a 26 gauge needle to give suprachoroidal injection effectively. So you can see we with the help of a scissor, we cut the sleeve of the intracath
with the help of a scissor, we cut
to almost half the length, and then we put it as a sleeve on a 26 gauge needle, and it goes freely into the needle. But you have to take care that terminal 1 millimeter of the needle should be exposed outside.
Calipers. Because if the beveled end is partially covered, then it will lead to extravasation of the.
Like for any standard
we have
injection procedure, we put a drop of betadine and we mark 4 millimeters from the limbus.
Then we inject triamcinolone. The
and
only
after
other
putting
precaution
Paracane, we take this needle, we have to keep the needle perpendicular to the sclera, and we have to apply gentle pressure so that there is a
small dimple
slight dimple is formed, and effortlessly
and
you
then
can
the
inject
can be given.
the drug in the suprachoroidal space. And we have used
in this retrospective study, there were total 20 patients with a follow-up of 6 months. The mean age was 49.45 years, and 70% were males. Based on presentation from onset, 45% presented within 1 month, 30% less than 2 months, and 25% less than 3 months. The baseline visual acuity improved from logMAR 0.75 to logMAR 0.36 at 6 months. This is a chart which shows visual acuity improvement, And similarly, there was corresponding reduction in the central macular thickness. The baseline CMT reduced from 454 microns to 285 microns. The re-injection criteria was a reappearance of macular edema with CMT of more than 300 and best corrected visual acuity worse than 6/12. So almost 1/3 of the patients, they required a retreatment. In these patients, intraocular pressure was also checked immediately after the procedure. The only relevant thing we found that immediately after the injection, the intraocular pressure used to rise, but subsequently within an hour and definitely in all the patients within 1 day, it used to come down, and there were no patients with raised IOP after at the end of the follow-up period. And on subgroup analysis, we found that BRVO had better final visual acuity, and initial visual acuity and CMT were determinants of good final vision. Safety-wise, there were no major concern except transient pain and redness. There was no significant change in the intraocular pressure. These are some of the multimodal imaging and some of the cases which were treated, which shows effective clinical outcome. There is another case where little amount of drug is extravasated into the subconjunctival space, but the clinical effect is complete. Thank you.
You are injecting anterior to ora.
Yes, sir.
Over the ciliary body.
Yeah, it is actually it is supraciliary in various trials also, like Tanzanite trial and all the trials. That is the distance they have used, and then it diffuses posteriorly because the space is open. So whenever we are injecting, the beveled end should be posterior so that the drug diffuses posteriorly, sir.
So in sometimes if we inject intravitreal triamcinolone, we use. So there have been cases of reported endophthalmitis. So we just go in and remove the triamcinolone which is present. Is there any way you can remove this from that place? If there is a this uneventful happening happens.
That I think would be very difficult, sir. I have never come across a case reported or in my series that they developed infection. But in case they develop an infection, that would be difficult to reach that space.
Now, how do you know it is suprachoroidal?
Sir, one is because the location of the space is at that depth. Then subsequently in some of these patients, we have done OCT, anterior segment OCT also, which shows opening of that suprachoroidal space. And in various trials also, they have compared the axial length with the amount of depth of suprachoroidal space. So generally, if the axial length is normal, then that space lies around 800 microns to 1200 microns, which is the length of this beveled end, sir.
Dr. Avdesh, you showed one case of VMT also.
Sir? Yes, that is an interesting case of BRVO.
Do you think that also improved?
Wherein the initial marker, the subfoveal detachment, which is because of the acute inflammatory process, because of BRVO, that settled completely. But those cysts, they appear that they have increased because of the traction. So they have that tractional component and it will need a surgical intervention in that case. But the subfoveal detachment, which is there, that has totally disappeared, sir, which is a marker of good response.